evening and welcome to We the People, brought to you by the League of Women Voters of Minneapolis. My name is Joan Higginbotham and I'll be your host for this evening's program. 1 out of 5 people will suffer from mental illness sometime during their life. Of course, that not only affects them, but their family members as well. Tonight we're going to talk about some of the programs and services that are available to people who suffer from mental illness and to their families. And we hope that by doing this, it'll give you some tools to help family members or friends who have these illnesses at this time. Our guest this evening is Sue Abderholden, and Sue is the Executive Director of the National Alliance on Mental Illness here in Minnesota. And Sue is a longtime advocate for the persons suffering from mental illness, so we're really happy to have you with us. Thanks for coming, Sue.
Well, thanks for inviting me.
Well, it was a startling statistic that 1 out of 5 people.
It's an extremely common illness, and yet we don't talk about it. So, you know, it usually is kind of a shock when people actually say, oh, I have a mental illness, or I have a loved one with a mental illness. It's something that we still don't talk about.
Now, why is that? I mean, that is one of the things I think I would like us to get out of this program. How can we feel more comfortable talking to somebody? I mean, and you're right, we don't know. It's sort of like talking about people with cancer. You don't want to know if you should say anything.
Well, I think part of it is the stigma, which is actually just a nice word for discrimination that surrounds mental illnesses, which we have done through every area of government that you can think of, whether it's Medicaid and Medicare discriminate against treatment for mental illness, certainly private insurance, housing programs, all sorts of things. And so I think people are afraid to share that because they don't want someone to think poorly of them. I mean, if you think about it, when we talk about someone with cancer, we use words like courageous, determined. When we talk about people with mental illness, we use words like violent. And so we need to change up how we actually view people with mental illness and start using words like courageous.
And it is true that somebody who suffers from mental illness, just to go battling on sometimes, has to be very courageous, and especially their family members.
Absolutely. And only less than 4% of the crimes committed in this country are committed by someone with a serious mental illness. So we really need to decouple those words. Because usually people with mental illness are more likely to be the victims than the perpetrators. But it makes it hard for a young person to say that maybe they are developing the symptoms of schizophrenia because they don't want people to think that then they'll be violent. And what we know is that the studies have shown that people wait an average of 10 years before seeking treatment. And even a young person who's experiencing their first psychotic episode, so they're hearing things, they're seeing things that aren't really there, they wait an average of 72 weeks before seeking treatment.
72
weeks.
That's more than a year.
Yes.
Now, would the family do the same thing, though? The mother or the father saying, trying to ignore it and so hoping that it will go away?
I think there's some of that. The other thing I think, too, since this is a young person's illness, so half of all people will start experiencing symptoms before the age of 14, 75% by the age of 24. If you think about the teenage years, how can you really figure out,
That's what I was going to say.
I mean, teens can be crabby, because actually kind of crabbiness is part of depression. They might slam the doors. So it's hard to know, okay, what's typical teenage behavior and what really could be the symptoms of a mental illness. And what we kind of caution parents to think about is what's the intensity and the length of time. So, a day or two, a couple weeks. When it starts turning into months, that's something you really need to take care of.
That's a really good point, because I remember reading about families who somebody said, well, why didn't they do something? And then, when you hear, as you said, you think about people wanting their children to be independent, or if they need their privacy, they'll give it to them. And so I guess it must be really hard as a parent to know when it's good to intervene, and you've given us some tips.
Yeah, absolutely. It's very difficult for families. And you often have to put school and home life together to know that there's actually something really going on wrong there.
Well, and I guess the other thing that I've heard, and I don't know how true it is that there is a huge shortage of practitioners and facilities and services for young people.
So we do have a shortage of mental health professionals, not just here, but actually around the country. We have a very huge shortage in terms of child psychiatrists, but not everyone needs to see a child psychiatrist. But even we have counties in Minnesota that don't even have a clinical social worker. So that really is a concern, and something that we've been working on legislatively as well.
Now, why is that? Is it because there's no money, or what is the reason for the lack?
I think there's a couple things. One is that the pay is not always good. Sometimes the hours aren't great, so that can certainly be a problem. Not a lot of, it's not an esteemed profession. Child psychiatrists will tell you that they feel like they're on the bottom rung in terms of physicians, and
Really?
yet it requires a lot of extra training. And the other thing is, you have to do, kind of a practicum, an internship where you don't get paid. And so not everybody can afford to do that. Last year we were able to get legislation passed to make sure that the rural loan forgiveness program it's extended to mental health professionals.
The what's it called now?
The rural loan forgiveness program, healthcare program.
So this is something where people can get their education forgiven if they
work in a rural area.
Practice in a rural area.
Right.
Well, I also recall another statistic that Minnesota has a very small number of counselors in the schools too. Is that true as well?
That is true. One thing I would point out, though, school counselors are not clinicians. So they have a different role to play in the mental health area.
The first person a kid might go to, or the teacher might say to the counselor, I think there's something wrong with Johnny. I mean, he seems to be having some problems, but there's nobody to say that to.
And we need to look at it not just about the counselor, but the school social worker and the school psychologist and the school nurse. So it's really all three of those, all four of those professions where students get referred to.
And again, is the family reluctant to say that there's something that needs to be treated?
Certainly there are going to be some families, but often we see families worried that something's going on and really seeking out help and not being able to get it.
And then getting frustrated, no doubt.
Extremely frustrated, yes.
Now, and I know that there's a need for sometimes for residential treatment too, and how is that for young people? It's not bad. The problem is that we have young people who might go into a hospital and they don't need that hospital level of care anymore. They need a lesser level. We actually passed legislation this last session that created kind of an intermediate. So we have residential treatment facilities, but we needed something that was more than that for kids who have very kind of extreme symptoms, whether it's maybe more aggressive symptoms or they have a medical condition on top of it. And they're called psychiatric residential treatment facilities, and so those will be built. We're hoping the first one comes online in July of 2017. And so that will help in terms of meeting those needs. There's about 300 children who are sent out of state every year because we don't have the programs that we need here. And that must be hard for the child and for the family.
Very, very difficult, absolutely.
Well, as we look at this, there is obviously a continuum. And are most people who suffer from mental illness able to be treated in their own homes or with supportive services?
Absolutely. People spend probably less than 1% of their life in a hospital bed. They spend the rest of the time, the majority of their life, in the community. So we need to make sure that they have the community supports that they need, access treatment, affordable supportive housing is certainly another piece. But most people can actually be treated in the community.
Now, do we have supportive housing?
We have some, not enough. The thing that's interesting when you look at the mental health system in Minnesota, a lot of people will say, well, our mental health system is broken. But I would say actually it's not broken. It's actually never been built.
Oh, well, that's even worse, perhaps.
Well, although I think in some ways it's more hopeful because it's easier to build something than to fix something. And we do know what works, and I think that's really the good thing. We do know what types of services and supports
Now, what are those services and support? What does work?
So we have a thing called assertive community treatment teams, which is like a hospital without walls that really help people with the most serious mental illnesses stay well in the community. We have in-home services for children and adults. One of them is called Children's Therapeutic Services and Supports, and for the adults it's called Adult Rehab Mental Health Services. What we know in looking at kind of our system is that if we look at all the services that work and we look at those across the regions in our state, that we have them, but not to the extent that we need to meet the population needs. So we have the foundation, we just need to keep building on it.
So you know what needs to be done.
Absolutely.
It's just a matter of having the resources to do it.
Absolutely.
And that goes for people as well as services.
Yeah. You know, it's a little harder in the children's area because on the adult side, we've actually added a lot of services and benefits to our Medicaid benefit set and to Minnesota Care. But children are typically served under their parents' insurance plan. And while we certainly have passed mental health parity, both in our state and on the federal level, it's not really being implemented. So we don't really make sure that we offer the same services through private insurance as we do through Medicaid, for example. And so it's very, very hard for families of children to actually get some of the services and supports that they need.
Now, I recall reading somewhere that somebody said, you know, if you have an ongoing health condition, you can keep going to the doctor until it's better. But with mental health, you have like X number of visits that you can make, and then supposedly you're supposed to be cured. And is that still the case?
Well, mental health parity is supposed to change that.
And does it?
Well, people have to fight it. So the problem is we don't have anyone, you know, kind of with a hammer saying, okay, you need to do this. And so a family would actually have to, you know, appeal that decision by the insurance company. The more difficult part of mental health parity, so mental health parity says you have to have similar quantitative limits. So if you don't set, you know, a particular number on physical therapy, you can't do that for mental health therapy. But you also have to look at non-quantitative limits. So what are similar services? So if you provide an in-home nursing for someone after they come home from the hospital, then you need to do that for someone with a mental illness. If you allow someone who has knee surgery to go to a nursing home for rehab for a couple of weeks after surgery, then you should also be allowing someone with schizophrenia to go to a rehab facility after they leave the hospital. But that's the part that we don't have.
And it's hard to, it's an apples to oranges, I suppose, for people, even though it really probably isn't so much.
Right. And you know, if there's new treatments that come out for other types of medical, you know, issues, new medications, new forms of treatment, your insurance typically covers that pretty quickly. When we have new treatments in mental health, we don't have that. So for example, one of the most exciting things that I've seen in the last 20 years is a new program. It's been researched both in this country and around the world, and it's called First Episode Psychosis. And the way to think about it is, the way our system works now is, say you have a 22-year-old that develops, you know, has their first psychotic episode, develops schizophrenia. We pretty much say, we're going to wait till you get so sick and you've been committed so many times that maybe then we'll help you. It's like if you go to your doctor and your doctor says you have cancer and says, now come back when you hit stage 4. That's what we do in the mental health system. Well, this turns that on its head. So we provide really intensive treatment to that young person. We put them in a peer support group. We do cognitive remediation. We make sure that they're in therapy. And we help them get back to school or work. And what we found is, while we can't prevent schizophrenia, we can prevent it from becoming disabling. And these young people go back to school or work, and the trajectory of their life doesn't change as much.
So really starting early.
And intensively. But private insurance doesn't pay for it.
And the reason is?
Because they have not figured out a way to make sure that new treatments are covered under private insurance plans.
But now that's sort of similar to the intervention. I mean, we've all heard stories of families who were really concerned for their person, and they weren't able because they weren't a danger to themselves or to others. And it seems to me that that's a pretty high barrier.
It's a huge, I mean, why do we want to wait till someone gets to that stage? We want to intervene far, far earlier.
But yet, that's
difficult to do.
Is that common practice? I mean, that's the way we've always done it, so that's the way we'll always do it?
Yes, and that's why this particular project is so exciting, because it really turns that on its head.
And it does work.
And it works, absolutely.
Well, that leads me to another question about, I know that the stories that we hear about are where the family calls because they do have a problem, and then the law enforcement people, are they, as a rule, not trained at all? Are some trained? I mean, it seems like we've had very bad outcomes in some of these cases. We have some trained, but not all, and that really is a problem. So it's kind of the gold standard of police training called Crisis Intervention Team Training. It came out of Memphis after they killed someone who had a serious mental illness, and the police chief there said we have to do something different. So they created this program. It's wonderful, but not every police officer takes it. And they used to say, well, just train the officers who really are interested in doing this work. But now we need to train everyone, because they really do counter this. Now, the other thing that's a part of this is that, why do we have a police response to a mental health crisis? Because it is a mental illness, actually.
It's a healthcare issue. And so back in 2007, we started actually funding what we call mental health crisis teams around the state of Minnesota. This last session, we got an additional $8 million so that we can make sure that they're 24/7 everywhere in the state of Minnesota. And so this is a great opportunity for families. They can call the crisis team. They'll come out. Sometimes they might come with a police officer if they're concerned at all, but it's really a way to resolve that. And then the person doesn't go to jail. You know, they actually go to a hospital or emergency room or a crisis home.
Well, that's the sad thing, that you often hear the person who made the call say, we just wanted somebody to help us.
Exactly,
And,
yes.
and they didn't know who to call. Now, is this information widely shared?
No, that's another problem. And one of the problems, there's actually, in the state of Minnesota, 40 different crisis lines. And so
40 different
numbers. Now, this last session, again, part of the legislation was that the Department of Human Services has to create one phone number so that we can really publicize it so people will know and they can call that number instead of calling 911.
Because I would guess that for some people, this happens unexpectedly. In other words, it's not like you know that you have a person with problems and you've already got the number on your phone or whatever. And so how could you ever find the right number?
It would be pretty tough. We have them on the NAMI Minnesota website, but it is tough. And that's why we really want to try to change that so we can have people intervening earlier. Because again, the crisis teams can come out when someone is beginning to get sick. I mean, why wait till it hits the actual crisis point and they might need a hospital bed? Let's really intervene earlier.
Well, now I remember when they had poison prevention. They had one number that you could call, and they had the little logo or whatever. And that's kind of what you need.
That's what we
We all need, actually.
And we're hoping that that gets done within the next year.
Because I'm imagining that this could even happen in the workplace.
Yes.
And again, that person, the person in charge there probably wouldn't have the foggiest notion what to do.
Right.
And we always turn to law enforcement because, I mean, in many cases they are the right people, but they aren't necessarily the people with the right tools.
Correct. Plus, again, we really want a healthcare response to a healthcare issue. We don't want to criminalize mental illness.
And is that really, I mean, you've said this a couple of times, is that really one of the issues, is that we don't think of it as an illness like other illnesses?
Oh, absolutely. It's not treated the same at all. And I think the other problem is that the symptoms of a mental illness are behaviors. And so people treat them as behaviors instead of as symptoms, and so our responses are then very different.
Like if somebody sneezed all the time,
Right.
that would be a healthcare thing.
Exactly.
But if someone has an unusual behavior, you don't immediately try to fix it. You just say something wrong.
Right. So if someone's, hearing things or they're paranoid, they think someone's following them, we don't think about that as a healthcare issue.
Now, you said that building building hospitals is not necessarily the right thing to do, but is there an adequate supply of places for people to go?
So what we really have is a flow problem, which is really it. So we want to prevent people from coming into the emergency room because we want to make sure that they're getting the supports that they need in the community or that a crisis team can help them. And then once they're in the hospital, they need somewhere to go when they're done. Some people can go back home and some people can't. So what is that step-down level? Right now we rely heavily on Anoka Metro Regional Treatment Center. And right now that's really backed up because half of the people who are there are waiting for a space in the community. So you hate to build the most expensive part of our system when it's a front door and a back door issue, and those are cheaper options. So we need to work on those as well. And again, it's building our entire system, not just focusing on one piece. And actually last legislative session, which was the largest increase in new dollars in our state's history for our mental health system, it wasn't just one place. It was really up and down the continuum and the array of services because we knew we had to build the whole thing. Because if you only build a hospital bed, then that's the only thing you have to use. And so we need that full spectrum.
Now, is there also some pushback sometimes in the community for some of these kinds of homes where people will go in a transitional place?
Unfortunately, we have had a problem, and not just even that. I mean, we've had a problem with even a children's day treatment center locating in one of the suburbs of the Twin Cities. We had a crisis home that was facing some opposition from neighbors, even though they're fine neighbors. There has never been any problem. So we were able to at least address one of the issues, but that can in fact be a problem.
Now, that really leads us to how do we educate the public?
I think the big thing is for people to really think about their own bias on this issue. Again, what are the words we use to describe mental illness? Do you use the word courageous, determined? What are the slang words we have for mental illness? Crazy, nuts, psycho. But what are the slang words we have for heart disease and diabetes? We don't have them. We have to think about how would we respond? Would we respond with empathy and say, what can I do to help? Can I bring you a hot dish? Can I take care of your kids? Can I drive you somewhere? All of those kinds of things. When I first came to NAMI and I'd start talking to people with serious mental illness, I would ask them, when you were hospitalized, did you ever receive a get well card? And they all said no. And you're not in the hospital for a day or two. It's usually at least 8 days. And so no one's reaching out to you to say, I'm thinking about you, you're going to get better, I'm here for you. None of those words of encouragement. And so we really need to break that barrier of silence and really start talking about it.
Is it that people are afraid?
I think they're afraid, and I think that they also don't understand mental illnesses very well. I mean, we have families coming to us who have a loved one, and they don't know what to do. It's not like you're trained to, handle someone who is having psychotic thoughts. None of us know what to do. And so we need to make sure that families get that training and support so that they can help their loved one and be good advocates for them as well.
But it's very true that people don't respond in the same way. There's no casserole coming over or offers to take care of the children, I'm just wondering how we can change that. And I suppose we're doing that tonight by talking to people about it. But it is. I mean, as you say, I think that people have always been sort of taught to be afraid of people with mental illness, and as small children, you're probably told you should watch out for that. And so it's it's not like a contagious disease.
No, and I think you have to remember that this is someone's son or daughter, someone's brother or sister that they grew up with a lot of love. They have people who care about them, and we need to kind of change how we treat people with mental illness in our society as well.
Now, Minnesota, you mentioned a number of things. Sounds like we are doing better than some states.
We are, absolutely. So we've had increases in mental health funding for the last 3 years. We've had states even in 2015 cut funding for mental health, including Iowa and Illinois and other states. And so, I mean, I'm not wanting anyone to think that I think we're a perfect state by any means, but people really view Minnesota as a leader, that we have done some really good things. We have a way to go, but we've done some very good things.
Now, why is that we are doing a good job?
Well, I think we've been growing a movement in Minnesota, so we have people who are willing to come to the legislature and talk about it. We have legislators who are willing to work on this issue. And I will say, kind of jokingly, but it doesn't really matter what the party is. We've been supported and screwed by both parties. And so, mental illness affects Democrats and Republicans, and so you find your champions and you get them to move forward.
And I would guess that your champions are basically people who have had family members in the system and didn't get the kind of care that they needed. So
yep, absolutely.
They
are willing to come to the table and fight for us. Absolutely.
That is really good. Well, and now as we move forward, what are the big holes in the system?
So I would still say we need a lot more community supports, especially for children. We have a program in Minnesota called Schooling to Mental Health, where the grants are actually given to mental health providers who then co-locate and collaborate with the schools.
Oh, really?
We've had this since 2007. And what we found is that half of the children had never received treatment before, and half of those children had a serious mental illness. Well, they weren't doing well in school. So it's been a very successful program. We've eliminated all the barriers for accessing treatment, but we're only in about half of the schools in Minnesota. We're in a lot of districts and a lot of counties, but only about half of the schools.
So is it in greater Minnesota as well as in the metro area?
Yep, throughout the state. We're in 79 counties.
And so what exactly would happen then in the school, sort of, if I was concerned about a child or a grandchild?
So if you were concerned or a teacher was concerned, they would let the mental health professional know, and then that person, with the parent's permission of course, could actually do an assessment to see what was going on, and then could provide therapy in the school. And the child's just going down the hall. The parent's not taking off of work and driving the child somewhere. The child is just going down the hall.
So it is in the school.
It is in the schools, but not provided by the school.
Now, I suppose I'm going to ask the question, you know, you're in the 6th grade, kids are so bad, and Johnny has to go down the hall, and you know why it is. It's because Johnny's crazy. I mean, is that what happens? How do you avoid that?
You know, it isn't.
Oh,
it's
really?
Really interesting. It's really normalized it in the schools.
Oh, that's wonderful.
So people are like, oh, there's Miss Betty, you know, and when do I get to go see Miss Betty? And so it has really been a very good thing. It has not, it's actually, I think, in many ways reduced the stigma and has not increased it at all.
Now, you do a lot of outreach in the community.
Yes, we do.
And what do you see, I mean, what is their main concern?
Violence is certainly one. And I think the other thing that we see, you know, frankly, that is somewhat harmful is employers not understanding mental illness in their employees. And so, you know, they are covered under the Americans with Disabilities Act, but you have to actually reveal the fact that you have a mental illness in order to ask for accommodations, and people are leery of doing that.
I can understand that.
And if someone becomes hospitalized, you know, while they're employed, sometimes the employers will say, well, we need a doctor's note that you're perfectly, you know, you're cured before you come back. And the problem is that employment is actually an evidence-based practice, meaning that people get better if they work.
As they're working.
And so really what they should do is whenever they want to come back, they should come back. And then maybe they can't come back full time. There's some very inexpensive accommodations that can be done to really help people come back and get back up to, you know, their kind of full working strength. But keeping them away from work is really not a good idea.
Well, you know, you want to be normal, and normal is having a job and going to work every day.
Well, and if you think about it, mental illness, some of the symptoms can be pretty isolating. And so what you want is a routine. What you want is to get in, you know, with other people. And think of all the gifts that people bring. And so we don't want to miss out as a society on the gifts that people with mental illness bring to our world as well.
And so there is a real need for employers to have more understanding also.
Absolutely. And we actually do a little kind of lunch and learn about mental illnesses in the workplace to try to start breaking down those barriers.
Well, that's what I was going to ask you, because it seems like that is something.
Yes. And what we'd really like to do is actually have small businesses and employers, CEOs, contact us, because we'd like to actually put together kind of a round table about how can we make this work better.
Well, I hope that you all, as you listening tonight, have learned a little bit about maybe what you can do. Send that card, bring that hot dish over. It's really something that could really help someone. And we'd like to thank Sue for being with us. Sue Abderholden, who's the Executive Director of the National Alliance on Mental Illness here in Minnesota. I think we've all learned a lot. Sue, thanks so much for coming.
Thanks again for inviting me.
This is Joan Higginbotham for the League of Women Voters saying thanks for tuning in to We the People. We hope you join us again.